EM board bombs.
And we're back. Hey, so we had a part 1 episode. We left you hanging. We purposely wore the same clothes, and 1 week later,
He's waiting the whole
we've been
time.
sitting in the spot waiting.
That's
We
it.
did take one shower in between. We just waited. We just waited.
Hey, so this first episode that we talked about was beta blocker overdose. The stem, I think, was one of our top 20 stems that we dropped, right? It was like a patient who refused to tell us that they were on Toprol XL, and we had to really just pull it out of them because they thought the Toprol was counteracting the Seroquel overdose and didn't feel like that. They felt like it was like a need-to-know basis that we needed to know that they had overdosed on Toprol.
He thought he was trying to help you, basically.
Exactly.
He thought he was like wearing his seatbelt.
He was trying to help us, correct.
He was trying to help you, yeah.
Blue Collar Podcast. We talked about, in the first episode, really diagnosing beta blocker overdose. That's a huge part of it. We talked about how it affects you. All that good stuff.
With lots
this
of hand
part
signals.
2 that we're talking about are the fun measures that we're going to be doing, the steps that you should do these interventions as well.
The maneuvers.
That's really important. So, hey, Briggs, let's talk about it. Tactical maneuvers.
The tactical
so ABCs,
maneuvers.
we got all that. We gave fluids, all that good stuff,
Yeah, exactly. Yeah. You should think about intubating these patients early. Let's be real.
Yeah.
Like, it's going to be a long day. It's going to be a long case.
Exactly. So
given
here's
the chance,
deal.
you should think about
for
intubating
you.
early.
You've given fluid boluses. You've given that glucagon as well, since this is beta blocker overdose. And the airway is okay right now. What are you doing next? The patient is still bradycardic, still hypotension.
You're bringing out the big guns.
Boom. There you go. You already did the atropine, by the way. Remember? In episode 1, we did the atropine.
That is the only...
Didn't do anything.
And it didn't do anything. Yeah, as usual, atropine never does anything. But let's be real. So, again, the airway we talked about should be secured if needed early on. Any signs of substantial change in mental status, the patient's going to go to the ICU anyway. These are sick people. A lot of procedures being done. If necessary, any doubt, just say, just go ahead and intubate them. Now, atropine can be given for bradycardia during RSI, whatever. Make sure you're primed for your blood pressure with RSI. We have to say it. I have to say it. Sure. I'm a believer in charcoal. In this case, would it be helpful? No, the patient's symptomatic. But in patients who come in and maybe they're not symptomatic yet and they took that extended release, I would totally try to give charcoal.
I'm not going to get involved.
Oh,
in
yeah,
this one.
totally.
I'm going to let you riff on the charcoal.
There's nothing wrong with giving charcoal to patients who are alert and oriented and can tolerate it. Especially with the amount of cost associated with this ICU stay. Totally. But in patients who are altered, of course, or risk for aspiration, absolutely don't give charcoal.
Yeah,
in patients who are symptomatic.
And to the toxicologists who are listening to Dr. Briggs, his email address, please, we will mention it at the end of this episode. You do not need to email me. So send those emails to Dr. Briggs. But I agree with Dr. Briggs. I think there is a role for charcoal. I do know that a lot of toxicologists don't feel like there is a role for the most part for charcoal.
There's also limited evidence for all this stuff.
So we're going to move on with that. So next up, Briggs.
So atropine we already talked about. You're going to give 1 milligram, repeating every 5 minutes to max 3.
Sure.
It's like we joked about, we often crap on atropine, but it really is not going to, I mean, let's be real. Like, it doesn't do a lot of things, even for severe bradycardia of other causes, cardiac bradycardia. It just doesn't change anything in a lot of cases. It's not going to go to the root cause. So in that case, you're jumping to the next step. And I know you already suggested it, but the glucagon is like that first thing that's given.
Sure.
We're not going to go over doses. You can look that up. This is a Blue Collar podcast. Essentially, what happens here is that they're just going to vomit. The biggest side effect here, let's be real, is going to be vomiting. Just be ready to suction. Again, the emphasis on the airway. If you haven't intubated yet, you might have to now. Glucagon, if you've given it for that food bolus because GI doesn't want to come in, it's going to be that classic just vomiting that happens. So the effect is often short-lived. You're rarely going to get a potent effect from it. And that leads us to literally the most important thing in this podcast is going to be insulin. The true workhorse.
There you go. Done. And it's high dose insulin euglycemia therapy is what you're doing. the glucagon, the atropine. People get so excited about these things. I get it.
They're just steps. Checklists.
They're just steps. You know, exactly. You just, as Dr. Briggs mentioned, you just click.
Right.
You know, that's it. What really is going to change things here are going to be high-dose insulin therapy. On boards, if you're given the option between high-dose insulin therapy or vasoactive agents, Briggs, what are you choosing?
You're totally going to do high-dose insulin therapy.
Boom. That's where they'll get you. That's like the second layer in managing this, right?
Right, of course.
Hey, Briggs, explain why high-dose insulin euglycemia therapy for beta blocker calcium channel overdose, why it's such a big deal.
Yeah, so what's crazy is first, this is not your, as I like to call it, not your grandmother's insulin, meaning that you're not doing, this is not like DK insulin.
It's not grandma's.
You are giving, it's not grandma's. You're giving potent high-dose insulin. That is 1 unit per kilogram. That is insane. That is a high dose. And what you're going to do here is give this insulin. The idea is that it improves, we're not entirely sure, by the way, like most tox literature, is going to improve inotropy. No, it's not their fault. I mean, how do you do studies on this?
I know. But send the emails to Dr. Briggs, not me. All right, continue on.
I love toxicology. I almost thought about doing it.
They're great.
The problem is that it's hard to do randomized controlled trials on these things. You,
but moving on.
As Dr. Hussain throws me under the bus as usual. He's so conflict avoidant. So the deal is here is that insulin improves inotropy at this like myocyte level, and the thought is it might help carbohydrate metabolism. It might help this stress myocardium get through this beta blockade, etc. I mean, look how we're explaining this at Blue Collar Podcast. Basically, just give it. It's the only thing that's going to help. This is
really going to be in conjunction with your pharmacy and toxicology. Wrong call, right?
It's the closest thing to an antidote in a beta blocker overdose.
There you go.
And it requires so much monitoring. Imagine you were saying, hey, we got to avoid hypoglycemia and insulin therapy for DK. Well, you are going to be even more concerned with giving high-dose insulin therapy. So giving dextrose to keep the glucose above 100, checking glucose almost like every 15 to 30 minutes initially. And the onset, however, this is so important, is that it actually is not like you give it in 5 minutes later, we're like levofed, we're in great shape. This, however, the effects of this high-dose insulin therapy, maybe this happened to you in your case, can be delayed up to about 60 minutes or so. So sometimes you're not getting that immediate benefit. That's what leads us into an adjunct therapy, which you mentioned earlier, which is what?
Vasoactive agents. But before you even start that high-dose insulin therapy, Briggs, what are you doing before that high-dose insulin therapy that you're doing for this beta blocker overdose? What are you doing? You're checking what at bedside?
Oh, doing the POCUS. We talked about that earlier.
You're doing the POCUS. Exactly. Right? So remember that we mentioned that in the first episode. Really want to emphasize that, because that POCUS that you're doing at bedside is really going to show you how fast that high-dose insulin therapy is helping, because you might see that delayed effect, as Briggs mentioned. Next up, you're doing vasoactive agents, right? Vasoactive agents work a little bit faster as well at times. You're using that as an adjunct if your high-dose insulin therapy really isn't working, or you're just doing it concurrently. That's in the real world what you're doing. You're doing your high-dose insulin therapy. You're starting your vasoactive agents. You know, oftentimes you're starting them at a higher dose, and then you're kind of titrating them down as well. You need to really be monitoring them closely. There is one vasoactive agent that we usually recommend. I love, Briggs, how you mentioned this vasoactive agent that you love so much. What is it? What is your favorite phrase with it?
Which one?
With levofed. You love levofed. You mentioned it's from
God's Presser.
God's Presser. There you go.
I thought you were talking about something else. I thought you were talking about, you got me confused with Vosin.
No. It's God's Presser. There God's you go. Pressure, you're starting some levofed.
I had an intern with me the other day who was like, it's obviously their first few months.
Right.
And they looked so like worried about which presser to pick in certain situations, and it was like, I believe it was cardiogenic shock, and they were like so cautious about what to pick. I was like, listen, let's get something straight right now. There's only one presser out there. That's the only one you need to know.
It's God's
There's only
presser.
one. You can go to the other ones later. And he's like,
it's
okay,
God's
good. Thank
presser.
you.
There
Thanks
you
for
go.
Yeah.
There you go. That's. Hey, I'm gonna shout out to you. Now I mentioned it myself with my own residents. I will bring that up. I give you a shout out, Briggs, as
Thank
well.
you.
Okay.
My heart warms every time you say it.
I hope so. But hey, we're talking about vasoactive agents started, high dose insulin therapy started. What are you also getting ready during this time? The ICU, right? So
or the transfer.
I say that because I had a recent, again, this is my patient, one of my residents asked me, they're like, so when are we going to, I'm like, has the ICU not been called yet? Because we don't need labs for this one.
Let's
go.
Just go ahead and do it.
Let's go ahead and get ready. All right.
Totally. And that's a big deal. So we talked about the high-dose insulin therapy, vasopressors in the interim, usually started concurrently.
Yep.
Wide QRS, and you're giving, it's like a game of charades.
Let's do it.
The hand signals, wide QRS.
When you get into close, what closes wide QRS
yes, exactly.
on every board test?
Exactly. Sodium bicarb. Yeah,
there
totally.
You go.
Any QRS you see on that EKG, it's greater than 120.
Yeah, there you go.
The idea is from that membrane stabilizing effect.
Yep.
The dose is 1 to 2 milliequivalents per kilogram.
Cool.
Just give them a nice little ampule.
Yeah.
And then we're getting to the stuff that's never. Oh gosh, I hope this doesn't happen to you in the ED.
Yeah.
The refractory cases.
Yeah.
This is where you're pulling out the lipid emulsion therapy,
Oh my
interlipid
gosh.
therapy.
Yeah. Good luck if you've got it in those community
you're
shops.
Bad luck. Well, they might if they have if they do hip blocks. They have to have a cart that has the ability to do lipid emulsion therapy. Think about it.
Yeah, and you really think that's going to be readily accessible to community
it's down the
EM
hall.
docs.
Down the hall, 2 buildings over at the outpatient orthopedic surgery center. Just have a runner.
Anyways, how is it supposed to work?
I don't want to talk about lipid emulsion.
All right, we're not going to.
So
lipid emulsion
against,
therapy, all right.
You can do it. You can talk about it.
I'm not going to talk about it.
It traps the
Moving on.
drugs in a little soap sud, basically. It's lipids.
Sure. Hey, what if all that's not working? What are we doing?
Yeah, so what next? You're never surrendering, and you're going on into, you're calling ECMO at this point.
Go.
If you have the ability to do that.
Pacing,
don't really do
consider
much.
It. Yeah,
Dialysis doesn't work either. We would have talked about that already. Don't worry.
Yeah, I know.
Yeah, so you're really in bad
ECMO.
shape. So we're hopeful that the high-dose insulin therapy, that's what our big selling point was.
Yeah.
That and some epi and norepi might change the game here. So let's go over some rapid pearls. Let's go into this. We got 5 points here to make that really important.
Okay, so these are 5 points for what?
Let's do it.
We're doing 5 points here
for beta
blocker overdose. Let's go.
Yeah. So remember the signs. We talked about this in part 1. Beta blocker overdose is bradycardia plus hypotension plus or minus CNS depression plus or minus hypoglycemia. The most dangerous one of them all is probably propranolol.
Yeah.
It's the most lipophilic. It has membrane stabilizing activity, and with that comes a lot of QRS widening and a lot of ultramental status.
Yep.
The ECG will show significant bradycardia. AV blocks probably wide QRS. The stepwise antidote approach is follows: atropine for mild cases, and by mild it means it's not going to do anything.
Sure.
Next is going to be glucagon. Why not? Not going to do it. Not really going to do anything. Next is the workhorse, high-dose insulin therapy.
Boom.
This is not your grandma's insulin, as we joked about. This is 1 unit per kilogram IV bolus. Insane. Regular insulin. Then at the same time, you're probably doing vasopressors for blood pressure support. It's norepi plus or minus epi, sodium bicarb if the QRS is wide, and then you're getting to the bottom of your knapsack here in terms of treatment options, top of the shelf, lipid emulsion plus or minus ECMO, depending on your resources.
Yep.
Hopefully you've already called the ICU or transfer center within that first 10 minutes.
Yeah.
Start insulin therapy early. That is the biggest thing here. You're not waiting until that patient to get worse. If you are concerned they are even just the teeniest symptomatic, go and start it. Do it.
Yep. Hey, Briggs, one of those points was great. We're going to go into beta blocker overdose. What is the stepwise antidote approach? Say it again.
Yeah, so stepwise antidote approach. Atropine first, probably not going to do much. Glucagon next, probably not going to do much. Next is high-dose insulin therapy, followed by vasopressors, sodium bicarb, lipid emulsion, ECMO. I love the balloons you just did. Thank you for the emojis.
Done. I hope you like the balloons.
They were wonderful.
That's
it.
Wonderful. Hey, I think we're done.
Yes.
Right?
This is great.
EM Rapid Bombs. Remember, 4 to 5 minute long episodes. Follow us on Instagram. We've been dropping a lot of high yield pearls on Instagram, getting revved up for boards that are coming around the corner. And that's pretty much it. We appreciate everyone's support. Briggs and I are going to be doing a live episode next week as well.
Yeah, that's right. The conference,
all right,
baby.
It's going to be fun. A conference.
Let's go.
All right. Briggs, anything else before we close out?
We're great. We'll see you next time.
Bye.
Bye-bye.